Evening, one and all. We have come to a stage where all the information needed, that is, the symptoms or what is palliative care, nearly A to Z of palliative care, has been conveyed in some form of or the other, either like completely knowledge based or with case discussions and variety of information, so that it makes things easy, convenient, and comfortable for all of you attending this program to have confidence to say that, oh, I can also set up a service and render this important service to those who need it. So, in that front, next is, how am I going to organize it? Have I got to do it all by myself? What help can I get? Many of those queries are going to be answered in our session today, for which we have a very lovely lady, Miss Sunanda Samal, who is good. As I have mentioned, all what I've said, she will be helpful. She'll take you through, she'll hold your hand, do everything like that as much as possible for setting up a service. So she is one of our regional coordinator for Central India, and she's also one of the state facilitation team in Palim India. Palim India has the state facilitation team and coordinators for all the 4 corners of India. She basically belongs to Odisha and is at present working in Pune. She has a master's degree in business administration and also in sociology. As I've been telling many times through this session, we need someone who knows social care, and she is good at it also. She has a very wide experience and she has 20 years of working experience in various sectors. She's been part of UNICEF, she's been part of many government programs, because as we saw in our previous session also, you need to know how to get, for example, narcotic drugs, which is essential and which is the backbone of rendering our service. So she is one who has experience in dealing with government setups also. And last but not the least, she has a good command of various languages also. That also is not a barrier. Oh, you belong to that part? Okay, I know the language, I can manage. So she knows these following languages to communicate: Odia, English, Hindi, Bengali, Marathi, and some amount of Gujarati too. So without taking much of her time, I hand it over to you, Sunanda, to take us through the session.
Good evening, all, and thank you, Radha ma'am, for that elaborate introduction. Okay, so, I'll just take a minute to share my screen. Is it visible?
Yes, Sunanda, we can see.
Okay.
Go ahead.
One, yeah, this bit. Just give me a minute, please. Is it visible in the slideshow mode?
No, you have to get it to the slideshow mode, Sunanda.
Yeah, now is it visible?
Yes, yes.
Just 1 minute. 1 minute. Okay. So let me just begin. So today's session is about organizing palliative care services. As Radha ma'am has already explained the purpose of this session. So I'll not delay and I'll quickly get into the topic. So let me first introduce about the state facilitation team. So this is a division which takes the Parliamentarians' work across the country with a vision to facilitate and access palliative care to all those who are in need. So details we'll be discussing in the later slides. So what will this session give you? The session will brief you exactly about how you can open a palliative care center in your region. You may be already part of some hospitals, or individually maybe you're already doing it. But for those who haven't yet started, so we shall guide you on how to start a palliative care center in your settings. So later on, we can have a Q&A session if you have some queries. So quickly, I want to move to the next. Just stop share and do it again. Yeah, is it visible now?
Screen is visible.
Yes.
To try.
But the slides are not moving. Just give me a minute. Sorry. Some issue. Sorry for the delay. So, as you can see in this slide, we have a WHO triangle. Okay, so we'll start with this. So, this is a WHO palliative advocacy triangle. We call it advocacy triangle. So, as per the WHO, to set up a successful palliative care center or to organize palliative care service, we need to ensure these three things. Okay, so as you can see, it is the education in one corner and drug availability in the other, and the policy. So coming to the education, there are barriers to palliative care, we all know, which will have to be overcome through education. So we all know that there is a lack of awareness among the professionals, lack of awareness among administrators, lack of awareness among the public. So it is essential to educate the public. So public demand does persuade professionals and administrators to think. So that's why education is very important and awareness is important. Now moving on to the next corner, which is drug availability. So pain relief, as we all know, is an integral part of palliative care, and for that, availability and accessibility of pain relief drugs is very, very essential. For example, morphine is the mainstay of pain management. Its availability has been eased to some extent, to a small extent, by amendment of the NDPS Act. But most states, because we work in different parts of the country, we have regional facilitators, so we discuss and we talk to the government officials. We know that many of the states are yet to implement. So here we are emphasizing on the drug availability, which is one corner of this triangle. Now coming to the policy and its implementation. So in much of the world, palliative care came into being because of individual initiatives and action by some non-government organizations. However, to achieve national coverage, palliative care needs to be integrated into general health care delivery system. So that's what exactly Pallium India is working for. So we want to integrate it and not keep it as an independent. So government action is also needed to remove barriers to access to pain relievers. It is essential for budding services to develop their own policies that can overcome any gap in available facilities. So when we plan for a palliative care, since here we're discussing about how to open a palliative care service. So when we plan this, we have to remember that you should be trained, you should have the opioids available to you, and also there should be a policy or a program available to support your service. So I'm just moving on to the next slide. If you have any queries, please post it in the chat box. We'll answer to it later. Okay. So now, just give me a minute, please. 1 minute. In this particular presentation, we are talking about the Indian context. So coming to the Indian context, we can see that we have three major categories. One is the standalone, which is a standalone hospice or a palliative care center. The second is a department. I mean, maybe a unit within hospital. It can be a government hospital, a charitable hospital, or for-profit or sustainable. And the third one, as you can see, is a community-based home care. So let us now discuss a little bit in detail. So what is a standalone? A standalone model is an independent facility where we provide palliative care with specific focus on pain and symptom management and improving quality of life for patients and their families as well. So this can be done through a hospice or a palliative care center. So in the next slides, we will see some photographs of standalone. Moving on to the next one. The next one is a department or within a particular hospital, you have a palliative care, dedicated palliative care center or a room or OPD. So this is, you have a dedicated room, which can be a government hospital or a charitable or profit-making hospital. Coming to the community-based home care, here it is a bit different. Here where the community gets involved. When we are talking about community, obviously the community comes into the picture. So here we reach to the care receiver where they are. So the team goes to the particular community. Here the social capital act as a bridge between the micro and macro, and the major element of the social capital is the volunteers. In the next upcoming slides, we'll talk about what is the micro and micro. So now we move on. It's not moving again. Is it visible?
Visibly normal mode, Sunanda.
Yeah. Wait one minute. What's the problem? Should I continue with this?
I think
Wait a minute. I'll just
we have to start from the standalone hospital.
now it's okay.
Yes, yes.
Yeah. Okay. So here, as you can see, some examples of the standalone hospital. We have Sipla, we have the Guru Ramdas Hospice, and few more. So this is again in Calicut, we have this one, and in Karunashra, this is in Bangalore. So these are all standalone. So now the next one, as we were discussing, within a hospital. So this is a particular hospital in which they have a dedicated room. So these are the palliative care services being provided through this particular dedicated rooms. Okay. Now we are talking about the community model. We want to discuss what is a micro, meso, and a macro. As you can see, it's showing that we have a micro and macro. So when it's come to micro, you can see there's only a one individual, and micro is a big hospital where actually the patients try to reach. But here you can see there's a meso, so which I was talking about, that the community, where the community is, the team is reaching them. Okay. So this is actually the Kerala palliative care model. What we do is we bridge the gap between the macro and the meso, and the team reaches out to the community and where the patient is. Okay. Okay. Now this is a very interesting story about one of our volunteers. So as you can see, his name is written. His name is Mr. K.N. Nair. So he is a very dedicated person, and he has been associated with Pelham India since his wife was actually like she was not well. So we call him fondly, we call him Nair uncle. He is 70-year-old and he's an ex-serviceman. So he got introduced to Pelham India as a caregiver for his wife who was under our care. He serves as a volunteer after his wife passed away. He goes with one of our home care teams and is involved in patient care more than our clinical team. So he's also known to our beneficiaries more than our team. He's so like attached to the beneficiaries. He always has a small notepad in which he keeps all data of the patient, and he keeps in touch with them over the phone almost regularly every day. Our beneficiaries are more comfortable to talk to him, call him, and share their issues. So he's never ordered, like as a volunteer, he is supposed to like do whatever is convenient for him, and there's no time limit. So he really is a very dedicated person. He feels as if he's doing these follow-ups in his own responsibility. So this is an example of our volunteer, Naira. Okay, now moving on. This is, as you can see the slide, it's a 10-step approach. So this is the crux actually. So these are the process we need to follow to start a particular palliative care services. So the first one, as you can see, is arranging funds. But obvious. So for starting anything, we definitely need some funds. So if you are a part of government hospital, there are funds available through various programs like NPPC or Ayushman Bharat. For private, of course, you can create a service and you can charge for it. If it's for charitable or individual, where the actual challenge is, for them we can go to the CSR or public donations. So you should have an idea which source you will be opting for. This is for the arrangement of funds which I'm talking about. So once the funds are arranged, we can think of recruitment of a or training of a team. So this is also an important aspect of setting up a palliative care service. Initially, you'll have a doctor, a nurse, and a social officer. So what we call as the basic model, in a particular basic model, these three are the required. These three people are the basic requirement: a trained doctor, a trained nurse, and a trained social worker. So going forward, as you grow, you may require allied medical professionals like pharmacists or physiotherapists, occupational therapists, dietitians. I mean, this depends on what kind of other services, extra services you're going to provide. So accordingly, you can hire. So as a basic unit, as I said, we would need a doctor, a nurse, and a social officer who should be trained in a particular palliative care training. They should have the basics of palliative care training. Now, coming to the next one is you should definitely have an infrastructure. So it can be a room for the OP or a space and a furniture for the inpatient unit, or in case of home care. Suppose you plan to start with home care, then definitely you need a vehicle which can be used by a team to travel to the needy with all essentials like medicine and other consumables. So I just want to repeat this. So when we are talking of only the OPD services, so just a room is enough. Just it can be a room, a particular space within a hospital. You can start with. For inpatient, definitely you need at least 5-bedded or depending on what infrastructure you have. And then coming to home care, as I said, obviously home care will need a little more of investment. So we're done with arranging of funds, recruitment, and then building of infrastructure. Then this leads to now we need to procure opioids. So as I mentioned in the starting, we need to ensure availability of essential narcotic drugs for pain relief. Obviously, when we're dealing with palliative care patients, we'll need this. So to procure, store, and dispense opioids, you need to be part of a recognized medical institution. Actually, in short, it is called RMI, which is a 3G certificate. 3G certificate, which we need to procure. And here I would like to mention that all the government hospitals are, deemed RMIs. They don't need to apply for any certificate. But other than the government, any private hospital or NGOs dealing with palliative care and want to procure opioids, they have to apply for this. So for getting this RMI, we can also help. Like we will can share the forms required, how to apply. So we can help out with this. So it's a lot of information required for understanding this topic. So you will have a different actually session on it. So at that time you can get all your doubts clarified. Now coming to the next point, after the procurement of opioids, now you have network building and establish connects. So you need to establish connects with existing experts in palliative care in your region, but obvious because you need their help. So this will help you to understand the local challenges and support available. So that's why this networking is important. Now after that, you need to arrange awareness sessions for the public as well as your team to help them know about palliative care, a little bit more about the palliative care. This will help you to get referrals as well as identify local champions who can take your work to more people. So that is why here we have mentioned create awareness specially because this is very important. Unless the need is created, people may not come to your setup. Now coming to develop OP. So developing an OP, maybe you can have a local hall as I was mentioning earlier, a classroom of a school, colleges, depending on which region you are and how where you're placed and how big you want to set it up. So just ensure that all facilities that you find are disable friendly. This is I just want to highlight this. You can just have an examination table, a chair, or some basic furniture and essential medical equipments for conducting an outpatient unit. So this is for the developing of the OP. Now coming to developing the IP. For developing inpatient facility, it'll involve little more infrastructure in terms of beds or side lockers, etc. I mean, I think you know better than me. So now coming to developing home care services. This is very interesting. You can start with one vehicle which can accommodate the team of doctor, nurse, and a social officer, and medicine and consumables. So there are scenarios where just a doctor or nurse go on a two-wheeler for home care also. So here I would like to just share my experience. In my last visit to one of the organization in Orissa, they have started palliative care, home-based palliative care. So they're using the local Ola Uber facility, and they're reaching the patient. So there are different innovative ways, and it depends on how passionate you are about to give the services. Now, the last, as you can see in this slide, the last block shows involve volunteers. So we all understand why volunteerism is important. So as mentioned earlier, just a basic flow that we follow. It's not a concrete rule. So whenever you want to start something new, you can refer this, but this is nothing like you have to follow this particular exactly. So you can have your own plans. Now, I've moved on to the next slide. So here you can see it says strategy, and there's a one triangle in the middle which shows government, for-profit, charitable, and sustainable subsidized. Sorry. So now we'll look into how we support, facilitate palliative care service with already discussed models. So here to the left corner, you can see capacity building. So capacity building is one of the major support that we are providing. Workshops, orientations, foundation course for doctors, that like the one you are attending now. Then for nurses, health workers, training of faculties. So there are various capacity building uh, programs we have. Okay. Now for opioid availability, the next one is availability of opioid. For opioid availability, we support in getting the NDPS Act implemented. We create awareness for medical institute about the new RMI process, and with the state drugs controller, we try working with NHM, the National Health Mission, to get the opioid included in state essential drug list. So basically, we are trying to make it easy, stepwise, to understand the particular system. So we do also handholding for the PCU at district level, connecting local palliative care networks. We provide documentation assistance and support. So also we help them in developing program implementation plan. For each state we have a PIP, so we help them in doing that. Implementation of NPPC, development of palliative care through health and wellness centers. These are all the government schemes I'm talking about, Ayushman Bharat scheme. So Parliament contributes towards developing a state palliative care policy. We do have regular connects with the Ministry of Health and Family Welfare for developing palliative care in states. So these are certain ways that we work. So we help recruitment also. We help recruiting human resources for starting a palliative care center. We facilitate cost management and sustainability. We help build funds through donations and help in grants and CSR application. We have new process called implementation team support. This is very interesting. So suppose any one of you is planning to set up a particular center in your region and you want a handholding support. So once the team is ready, so we'll send an implementation team to a region. Our team of, it can be a doctor, nurse, and a coordinator to your site. So they'll stay there with you, handhold, and it can range from about 1 week to 10 days to even 1 month if required. So of course this will be a paid service, like that we can discuss later. So this is something we are coming up with and looking at the demand all across the country. Okay. So now we have talked about how it should be done, what are the facilities, how we can go about it, what are the steps. Now let's discuss a little bit about the challenges. So it's very clear in this particular slide. So we have just separated the government limitations, like government challenges. So let me just pick up the government one first. As you know, we have limited budget for palliative care. Then medical college, medical colleges that are dependent on state budgets, so no provision. Then palliative care is not a priority among all programs. As you can see, there's a communication gap. There's a reluctance in collaborating with NGO. The trust issue is there. Then getting an appointment is always a issue. Then we have to do endless follow-ups. These are the things. Now, general challenges are like you have, you know, want some you for the palliative care setup, people want to just play safe, and that's the reason many of the states they do not want to go for this license. This I'm telling about with my experience, because when we talked to them, they said no, we are happy with the old license. So it's all about they don't want to take the risk, and of course, inadequate knowledge is one of the reasons. Then they do not have trained human resources. And the most important, as you can see, we have highlighted it, they do not consider it as very lucrative business. It's not a money-making business. That's the reason it is uh, not taken, people don't take much of interest in this. Okay? So moving on from the challenges, and I think this is not the only challenges. There might be many more, but we have not jotted it down. So we just put down the basic ones. Okay. So now, as you can see, this is a standard audit tool for any palliative care program. We suggest that it should have a this kind of audit tool. So basically, it is a kind of self-evaluation audit tool for palliative care centers to know where we are standing. So there are two parts. Part A, as you can see, is essential, and part B is desirable. So obviously, essential means that it should be there, and the ones listed in the desirable are regular requirements, as you can see. So we can just skip this for now. Okay. Coming to the next one, let me explain a little bit about the Palamandia model, how we work here. So we in Palamandia follow a model called DEF. So D stands for demonstrate, E stands for educate, and F stands for facilitate. So facilitate is the group, the team where I work. Okay. So let me go one by one. So for the demonstration, let's discuss. So the demonstration model is a proof of model that we take to our stakeholders so that potential stakeholders like you all can learn how to deliver palliative care. So here we have tips in Trivandrum. This is Trivandrum Institute of Palliative Sciences. Many of you must be knowing it, which is also a WHO collaborating center for training and policy for access to pain relief. So for the D, this is how whatever we do is demonstrated there in tips. So this is the Palamandia's office, Trivandrum Institute of Palliative Science. We call it tips. Okay. So we have inpatient care, outpatient, home care. So these are the facilities we have there. We also do rehabilitation, community participation. We have link centers. We have halfway home. So quickly now I want to just give you a information about our palliative care helpline. Okay, so here you can see that there's a helpline mentioned, and here I want to also inform. I'm sure many of you must have tried this. So what happens is that many people call, and then there is a they expect that somebody at the other end will respond, but that doesn't work that way. You have to say your message after the IVR. I mean, sorry, the beep. So after your message is recorded, so the team will get back to you. So just I wanted to explain and tell everybody, because so that don't get disheartened that this number is not working. Okay. So quickly resuming the previous thing. So we were talking about the demonstrative model. So now is we're talking about the education. So in education model, I discussed earlier that we do the lots of kinds of trainings, which includes for doctors, for nurses, volunteers. Here I want to mention we have beautiful program which is free of cost for volunteers. Since we are emphasizing more on volunteers, so we have volunteers training happening in Pelham India also, which is also online. It's a 5 days training program. So anybody can attend it, and we also get a give you a certificate after the end of the training program. See here, we have jotted down some of the courses. For the doctors is FCPM, which is the online one, which you all are attending. Nurses we have, for FCPC we have FCPC's foundation course in palliative care, which is for the uh, all allied healthcare professionals, not necessarily doctors. As I was mentioning, volunteers also are there, student volunteers there. So a lot of trainings, and this is just a list, a lot more. So just to give you an idea about what all we do in education. Okay. Now coming to facilitation, which is the DEF. When I said DEF, so for F we have facilitation. So here I would like to emphasize and explain that we have 4 regional coordinators, facilitators in different regions. In North we have Rajendra, who is based in Uttarakhand, and he looks after all the northern region states. So in the Northeast we have Rontu Sangma. He's based in Guwahati and he looks after the northeast parts, all the states, specifically the Seven Sisters, and also he looks after the West Bengal. Okay. So in central region, I'm taking care. In the south, we have Mr. Lalit who takes care of all the south region. And now we have a new person, Mr. Askari. He's joined recently, so he'll be also managing some of the states. So I think all our contact details will be shared to all of you. So you can pick up and contact us as per your regions. Okay. So these are in the map we have shown which are all the states we are taking care. So first one is the north, and this is the northeast states that we're taking care. Then this is central zone and south. Okay. Now, just quickly, we are moving on to little bit more about the facilitation. So, what is the philosophy of this particular team, state facilitation? We actually aim to integrate at all 3 levels, the primary, secondary, and tertiary. So, basically, we have the following 5 objectives. First is the catalyzing palliative care centers and services. As mentioned in the beginning, that we help in end-to-end facilitation. For example, if any one of you contact us that yes, I want to start. So from there, our handholding will begin. Like we will share you the guideline, and then we'll understand what exactly you have, like where you already have some infrastructure or you have trained people. So then we'll start from there. So it is end-to-end facilitation for catalyzing centers across various categories. It can be in government also, in charitable or for profit making also. Okay. So this is the first one. Second is we assist in opioid accessibility by facilitating in getting the RMI. I was talking about the RMI certificate. So this is a long procedure that involves which you will learn through opioid availability session later on. So we help our stakeholders to go through each documentation like filling out applications, talking to the drug controller, maintaining records, etc. So here I want to say, just explain how our team works. So as a regional facilitator, in every state, there are 2 major government departments that we touch upon. One is the National Health Mission and second is the State Drugs Controller. In some states, it's called the FDA, Food and Drugs Authority. Like in Maharashtra, it is called FDA. So we reach them, we find out what's the status, have they been issuing RMI. So then it becomes easier. Suppose somebody in Maharashtra contacts and we know that it is already being issued. So the process becomes easier. If it's not started, then we need to talk to the drugs controller, convince them, take some sessions with them. Then it takes a little bit of time, but later on it is done smoothly. So this is our role in facilitating how you can get the particular license. Now, we enable palliative care learning in medical institutes. So what we do, as we all know, that education plays a major role in delivering palliative care. We try to work with medical institutes to involve palliative care in their undergraduate curriculum for doctors. Here we work with the trainers. So then they train the students in palliative care. This is also a beautiful system in place that we do. So this also helps in a lot of awareness among the medical students. Then we work with stakeholders to help them build community engagement and help them mobilize volunteers. As you all know, Kerala model is mostly volunteer based. So here in Palavendia, we create a lot of awareness among the public, get similar interest people together. Then they form a group as a link center and they take ownership of palliative care across their region. So it is not, it is actually from the volunteers to the service setup. So they demand that, we have palliative care patients in our region and we want your services. So it's like that. Then we do have pain-free hospitals. So this objective is a budding state right now. We do not have much, but then the concept is where any patient that enters for any treatment is assessed or treated by the pain score, and the pain score is measured by a scale which ranges from 1 to 10. Okay? So this is basically the philosophy of our team that we work for. Here is the national president, that what all we have done in different states. We have reached so many state governments, and we've done catalyzed so many centers. On-site foundation. On-site is the team is either they invite us to their region or they come to Parliament. Then we have faculty development programs and hands-on training, opioids. So we have many activities happening, as you can see in the map. So different activities happen. It's not, it's not uniform all across the country. Different things happen, but mostly most states are covered. Yeah. Thank you. Any questions? Shripriya, I have not seen the chat box. Just stop sharing.
Until now, there were no questions.
No questions. Okay. Okay. Thank you very much.
At present, there are no questions, Sunanda. We'll just give few minutes.
Sure. And
then
any particular slide, if you want me to repeat, I can.
That's what.
Yeah.
We'll just wait for them. And one thing, just as you were talking, came to my mind. Even private setups, you do help. I remember you sharing something which you had done in Mumbai. Would you mind doing that again?
Yes. Yeah, sure. I'll do that. So what we do is, in Fortis, I'm sure you must have heard about Fortis Hospital. There's a chain of hospital, private hospital. So recently they contacted us, and as they wanted to start a palliative care center. So after a few meetings, we realized they have an infrastructure, but they do not have a trained team. So doctors and nurses and social workers. So we then asked them to register with our training. So they finished the training, and then recently last month they opened the palliative care. It's a not a standalone. It's a within the particular hospital. In the Fortis, they have a dedicated room for the palliative care OPD, which is going on now. So they're doing it nicely. So where we understood that some places they don't have staff or trained staff. Some places they don't have infrastructure. So it depends on different regions. First, we need to ascertain where they are, what kind of help they need. So and some places they have trained everything. They have infrastructure, they have trained people, but they do not have the license. So then our role is different. So we just get into the RMI thing and help them out. That's what.
Exactly. That's what basically through your thing, I was just thinking that, see, each person's need, tailor making to your need, and need not be the same. Sunanda gave some examples. So even beyond that, something very simple, You may have how to contact, how to go about with awareness education. So for every element of it, because excuse me, PALIM has been helping all over India. And above all, you have the model or the demo unit you can go and see in Trivandrum. That is one option. Or the team comes to you. So both are being done, and then according to the need. So that's why I wanted her to give an example. It's not only government, private, small setups. It is based on what, see, ultimately, we are hoping and aiming, as Dr. Rajagopal always says, we want to take this service to everyone, because it is something, see, more often, Sunanda, they have had the session on opioid availability already. So even that has been highlighted, and it's a medicine which is so cheap and available and so useful. It is still the gold standard for pain relief. So in all ways, we are trying to help you, so that, and many teething issues will happen only when you start. So that's why we always say, start slow, go slow, and then you will be able. First itself, I want to start a big setup, you may burn your finger, which you need not do. You can have a better experience. Start off just with an outpatient service. Go ahead, do for a few months. Get an idea what is the number and capacity, what is the demand, need, supply. You tailor to the needs. Like that, if you go, it will be helpful. There is a question in the chat box, Sunanda, let me read that. How can we identify the palliative care needs of the people, for example, the elderly patients with poor functional status? Based on, like, you have any, like, multiple tools are there. For like elderly means, is there dementia? You have those assessment. These are all, like, they are there for each specialty type of thing. All these tools are there. Dementia, like basic dementia assessment, and even in your end of life care, that Walter index, what he mentioned. So there are so many tools available for you to find out what is the need, where is the need, where does that patient stand there. So like that, you have the primary assessment and then take it from there.
Ma'am, I want to
So,
give a beautiful example
go
which
ahead,
Dr.
Sunanda.
Raj always gives. That as we all know, palliative care is, not only about physical pain, it's spiritual, financial, emotional, everything. So he gives a very lovely example that we met a patient and day one, and then we asked him what's pain score, like, pain score. So he said, first he explained his issues. What is his issue? That he knew that he's not going to live for long, and his wife doesn't have any skills to earn, to earn. He was only earning member, and his kids are still in the school. Okay, and suppose he passes away, what will happen to his children's education? So in the pain scale, he said 9. Suppose, I don't remember exactly, but he said 9. So later on, it was taken care. So his wife was given some skill training. He was from a poor family, so his two children were given education support, everything. Then later on, after a month or so, or 2 months, when the score was assessed, the physical pain is still there, but his pain score has gone down to 2 or 3. Why? Because for him, that worry is important, that after me, what will happen to my family. So here, we should not by default think that it is always a physical. We have to ascertain, as you rightly said, Radha ma'am, that what exactly, every patient, it will differ. So for this particular ex-patient, it was his family, it was bothering him. So that's why he's given a, like, lesser pain score, though the physical pain remains the same. You can add on to it, Radha ma'am.
What Dr. Rajagopal always says is, again, no, so he is like, he is guru for all of us. And he has done it and succeeded. So why not take that? So one thing what he always says, he puts it very nicely. He asks them, what is that is most bothering for you? Okay. So the example what Sunanda gave only, see, physical, so many things are there. But for that particular person, being the head of the family, always, what is most bothering his kith and kin? His physical thing will be there. So physical, social, their social, psychological, and emotional have overtook his physical. So that's why you ask them, when you ask them what is that's most bothering for you, then it will come. And that may not come on day one, because first day they are seeing you. We all know that. When we do medicine, what do we say? Gaining rapport. What is that gaining rapport? They having confidence in you to reveal what is the most sensitive for them. Will we do that on day one? No. All of us have so many reservations and comfort level and so many things, isn't it? So that is why we say total. That total may not happen in day one. And it might happen also in day one. How and when it will happen on day one? You and the patient, you have the best communication skill. Your body language. See, even that we have gone through. So if everything hits the right spot, it might happen on day one. But there's no assurance that it might happen on day one. If it happens, well and good. So like that, so that is what is important. And one more answer to the question is, you have to see what is the need in your area and what is that you have to face and see, and then accordingly. That is why we say start in a low level, but minimum these three people, like a doctor, nurse, and social worker, is bare minimum. Because see, as a doctor, you may not be able to cover everything. The social needs are also equally important, because this itself is a sensitive issue and very secretive issue, and it has a lot of emotional aspect on it. Be it, see, many times we say, why are patients, they are in a situation or state, they are helpless, they feel so lonely and unable to cope. So that is where you have to spend time and get the right thing. There's another question in the map. We saw some symbols in Manipur.
Radha ma'am, we have a beautiful video. Can we show right now with your permission?
Yes, we can. And there's one question also I will read, maybe that you can clarify in the map. In the map, we saw some symbols in Manipur. What or which palliative care facilities are available in Manipur linked to tips? Can you just answer that?
Yeah. So for Manipur, as I said, Mr. Ronto is taking care, and also we'll send you the share the link of our website directory, so you can just get into that. Okay.
And that map, as such, doctor, has got so many things. Like in the map itself, on the left side, you'll be shared this presentation. So on the left, if you see, all the symbols have the explanation. And more than that, if you think something is not clarified, you can get in touch with Sri Priya or the team, so that everything is clarified. And all four of them I have met. Okay. All four are equal gems. And they all go out of the way to help you. So feel free to get in touch. All four of them, Rajendran, Ron to Sunanda, Lalit, I have worked with all four of them. Okay. So feel free, and they will, one excels the other. So don't worry, you will be able to get. And then there are two, if you see, there are two pain centers also, pain-free centers. So all forms of contact, support, everything is available. And let us go ahead with the video, Sunanda.
Yeah,
and then
Shri
we'll
Priya,
come
if
back.
you can help. Thank you, Shri Priya. Any more questions there in the chat box? I don't see.
No, nothing at present, Sunanda. See, exactly what we were trying to explain only was shown in this video also. Okay, there's a question that what is CCPM? Course for Dr. Vipal. It is the in-house program.
Just like you're doing the FCPM, ma'am, so
Mhm.
Dr. Narayan. So that is the in-house, as rightly said by Rajra.
It's like a 4-week, 5-week program. If you want to attend, you can attend that also. You will have The same, like education, information, all what you're getting. Plus, you will do in-house training, you'll do home visit. Everything is done in Pallium itself.
If I could add in, Radha.
Add on, Sripriya, please. I was about to tell Sripriya, please add on and then come.
CCPPM is somewhat similar to just like Radha ma'am said at the FCPM. The only difference being it would be on site. It would be a 6-week comprehensive course wherein you will be getting all the theoretical class, and over and above that you'll be having practicals. Like you would be assigned duties in the IP setting, the OP setting of Pallium. You'll be taken to home care visits, special visits, field support, everything, so that you will get to know A to Z of palliative care. How starting from how we identify the beneficiaries, how their assessments are made, what are the kinds of supports to be made, how their documents are being kept, the entire thing that you will come to know with the CCPPM. That's it. Ma'am, you are muted.
Add one more thing I would just like to add on is about that halfway home. Because that is something, again, see, there is a full-fledged physiotherapy, rehab unit, everything is there. And on top of that, this halfway home is for people. See, many times you give training, rehab, everything, but still the patient or the caregivers don't have that confidence. Oh, if I go home, will I be all right? Can I do everything by myself? What happens if I fail? So even that is helped, whereby in this halfway home, they have facility to live as they would live at home. So they will do everything by themselves, but under the care or like someone is there. So that is something which is very helpful, and I've seen patients who are there after that, so they themselves gain confidence. Okay, we'll go home, we can manage. Where they have facility to cook, do everything. Plus, if they want some help from the rehab team, that also they get. So that is something which is very useful. And at least 2 patients are there each time, where they can stay in that service, that part of the unit, and gain confidence and belief in themselves, which is very important. Everything, see, that is what no self-confidence is. Even though they do everything, but when they are there and constantly seen, and then they themselves say, okay, I am okay, now I can go. And then even after that they'll say, okay, even if you go home or go to somewhere where you are, so once a month or get in touch with us, or they will still go see them, they're okay. So those type of facilities also there, which is very useful and something worth mentioning and applauding.
There's one more question.
Is a certified course in pain and palliative medicine.
Yeah, I was just looking at that.
Yeah. And please don't think that it is only through these courses that you can pay visit to Pallium. It is not like that. Our participants are always encouraged to visit Pallium as observers also. Even if your busy schedules don't allow you to stay back for 6 weeks, you don't have enough leaves. Please don't worry about that, because you can always join us as observers for a couple of days or 1 week, like that. Everyone is welcome. Just wanted to inform.
Yes, it is really worth. I would say not only for that, especially the home visit is something, because see, palliative care service, you will have patients who are in a state where they cannot come to hospital. Okay, the same patient in one, like when you see them initially, they may be mobile. Okay, so through the line or through the time, they get to a stage where they are unable to come. So at that point of time, home care service comes very handy. And sometimes the carer or someone may be able to come. So home care service is something down the line. Initially, you may not have facilities to have everything. So that is something to be kept in mind. Or it can be the other way also. There are some, as Sunanda mentioned, there are some places where just one person, two people, like see, all what was mentioned of breathing, you can use an auto service. Okay, if you have a very efficient nurse, trained nurse and a social worker, you can provide these services in very many ways. So either with an ambulance, fine, or you can use services. So like that, to know what all is done for that, to know or to have a very good demo of home care services, Palim is one of its kind. Every day you have 7 home care teams going. From the most, like they have something called as fast track, very sick patients, 2 routine patients, everyone is covered in it. So that is something where every team may have a doctor or not. They try level best to have a doctor. Otherwise, it will have at least a nurse and a social worker. Or again, all that is need based. Okay, we are going there where we have issues where a social worker is needed. So we have to deal with something. So then a social worker will come into that team. Or you have someone who needs rehab. So then a physiotherapist may come. And the whole team works so hand in hand, from the driver to everyone. Everyone helps each other. That is how. There's team working is another quality. Communication skill and team working are something which we have to develop. Okay, for the benefit of the patient and for the benefit of each member of the team. So that is another thing where, like from the driver to everyone, they will work so hand in hand, because that's needed. If the nurse and the driver don't coordinate of what the patients they've got to see, they will waste the whole day. If they coordinate, they can do very well and be very efficient, see as many patients, have a nice day, you're doing such good service. It's hard work. And in turn, you can also be satisfied and fulfilled at the end of the day. So that also is something worth seeing.
Ma'am, I just want to share that we
Add
can
on.
also, yeah, as I was mentioning about Orissa Home Care, one of the organization, they're doing home care. So they actually do not take doctor every time, as you were just sharing now. The nurses are so well trained that they will go to the patient, and first they'll do all the vitals and then talk to them. So I saw, my observation was that the nurse is not only the nurse, she's such a good counselor. So it's, as you said, the communication skill, I mean, it doesn't have to be only good for doctor or nurse. I mean, she has to, inculcate that, and she's picked up so nicely. The team that I went along with, I was just observing, she did both the things. She did the nursing part, and then she spoke to the wife of that patient, and the other part, like counseling part. So it depends on what kind of setup you have and how you want to do it. And as I said, they use the public, I mean, the Ola and Uber, and then they go. So there's no limitation to it if you really want to, do the service. Yeah, thank you.
Exactly. See, that is why we always keep telling. Even where I have worked in Chennai in Adyar Cancer Institute, where we didn't have that many doctors. Okay, because we had a full-fledged inpatient, outpatient. We'll get 30 patients, 30 to 40 patients every day in outpatient. Okay, and we'll have inpatient also. So in those situations, what we'll have, we had only one doctor whom we could spare for home visit, but the number was increasing. So slowly we were training our nurse. Nurse also had been there for a long time. We had a very senior nurse and another few more nurses. So we will send the nurse on some days to go review patients whom we have seen. So there are so many ways. So nursing team, they are like, see, we have seen wound management, so many ostomy care, so many things are there for which the nurse can be very helpful. And you have to teach. And then this, through our sessions, you have seen how to help and teach them to do dressing material, everything, oral solutions, cleaning solutions, everything can be homemade. Okay, and if the nurse goes and teaches them, she literally demonstrates to them. Even when we go for home visit, even when I did home visits in with Palim in India, in Trivandrum, I remember for one of the, like, mother was the carer for the daughter. And literally she's in a state where she cannot afford. So we sat and showed her how to make those gauze dressings. And then she said, oh, if it is like this, no problem. You've taught me, so I will make my life easy. I can't buy. But if you tell like this, the mother was willing to learn and do it. So the nurse can play a big role. And if you have a social worker with her, so the nurse and the social worker, or the nurse herself, is all nurses excellent they are. Okay. And as Sunanda mentioned many times, I've had that experience also, because the number of patients and the volume they see, they will be very good counselors. And the way the patient speaks itself, they will pick up. Oh, she needs this. She's in a state, she needs some extra time. If I sit and talk to her, she will reveal more, and I can make sure that she's comfortable. Because see, the carer also has to be looked after. So all those things you will pick up issues only when you go sit and talk with them.
I want to add something.
Yes, and there are some questions also in our city, how to practice palliative medicine after the FCPM course. You
Yeah,
are
I had
from which
asked Dr.
city?
Narayana from which city. He
Go
has
ahead.
replied, Mangalore. Yeah. Sir,
Go ahead, Sunanda.
yeah. Dr. Narayan, I would request you to get in touch with our South coordinator. So he will guide you. As I was just telling through my PPT that for each region we have people. So that is the whole purpose of this particular session, that we want as many as palliative care centers. And just now I wanted to tell that only of my experience. I want to tell all of you that we all know Pune is a big city, okay, and we assume that there are many palliative care centers. You will be surprised and shocked to know I've been struggling. There are cases coming into me, and I'm struggling to connect them, because we do not have palliative care centers in Pune. Forget about all the other remote places. So I urge all of you that you have this beautiful training going on, and after that you all have all of us to guide you. So please start. We want as many as palliative care centers all across the country, because if this is a scenario in a place like Pune, which is supposed to be a smart city and whatnot is there, and I must tell you, except Sipla Palliative Care Center, we do not have anything. All are different small individual doctors taking it. There's no setup, and people are struggling. So I feel very bad being in this position. We have to, and there's a patient right now I'm looking after, like contacting their family members. He's not in a condition to be shifted to Mumbai also. So they want a center in Pune, and I cannot connect them with. So that's why whoever in this particular team, any doctor who is from Maharashtra, if you're from Pune, so I really want to request all of you. We want more and more centers across the country. Please, think about it and take our help. We are there. In any particular stage you are stuck, we are there. And as Dr. Radha was saying, you can anytime plan your visit to Pelham India, and there you will get to see everything, and you can meet Dr. Rajgopal, which everybody I'm sure must be longing for to meet him. So he's always available. You can just find out when he's available, and we can plan a visit. So only now, I think after this training, only thing is that you have to jot down your regional coordinator's number and then connect with the person. That will make your work easy. So because I don't know from wherever you are. So just note down the number and you can contact the person. Thank you.
See, what Sunanda has said is the situation in many cities. Okay. Even Chennai is not an exception. I am from Chennai. Okay. I don't say that there is no palliative care. I have used the service for my own family. Okay. But very few are there. See, always demand supply. These cities are all massive. Okay. And the number of patients and families in need is out of proportion. The services, for example, 4 or 5 are there. Okay. And 4 or 5 to cater to everyone, is it possible? We are literally extracting maximum from these 4 or 5. And out of the 4 or 5, home care, I think 1 or 2 does. Because home care is not easy to provide. And see, the cities are expanding like anything. So some places say, no, we can only cover where our setup is. Maybe 10 kilometers round. But the city has gone 50, 60 kilometers away now. So those practical difficulties are there. Okay. So the other things what I would like to convey is, see, through this presentation and everything, we have given you the ways of communicating to the regional coordinators. And another thing also Sri Priya will share is your, like, all of you who want to attend like hands-on training, there are recognized centers all over India, which Sri Priya will share. So you can find out those recognized centers nearby to you. See, as we have been telling, everyone has their own commitments. Can you spare like 2 days, 5 days to go to Trivandrum, or is it too far? So that is why we are going, Sri Priya will be giving you the link of recognized centers all over India where you can go and have some hands-on. So that is another thing. You can look into that, then also get in touch what you want to do, and then take that from there. And this thing will be complete only when you do some hands-on also. Because as I told, for the halfway home for patient, no, we also have to have confidence and belief in ourselves that we can manage these type of patients. So those are things, Sri Priya, am I right or not? You will share with them the
Ma'am, I will share it today itself.
Very good. So that is something
And
which
also
we
I
have
want to
to
tell ma'am about the hands-on training. There's a very interesting thing. Again, it's my experience. So the doctor finished the FCPM, and she's basically from I think Andhra. Okay. So, but for hands-on training, she preferred a hospital in Chhattisgarh, because that is her home state. So this is also possible. I mean, not necessarily you have to be in that particular state, because she then got in touch with me, because Chhattisgarh I am looking after. Then I coordinated and I connected her to one of the hospital, and then she's finished her hands-on. So I just wanted to share that it's not that in the same state you have to look for it. If you have some place of stay or anybody you want to go there, that's more convenient. So you can choose from that list too in other states also. Thank you.
see, the main important thing is doing hands-on. Okay, you do it wherever, because as I said, no, everyone should gain confidence. See, mostly either you have just finished medicine, you want to take it up as a specialty. Yes, very good. Even in that front, all over India, 6 medical colleges have already started MD palliative care. Okay, and DNB also 6 centers are doing. So to start off afresh, someone finishes one subspecialty I want to take, yes, that option is also there. Okay, next I come to people who have already you're specialized in some field, but still you want to do this. That option is also there. So in that front, so you just doing this is, you already have the skill, you've added on additional knowledge and skill what is needed now, and then you want to go down and do it. Okay, from that point of view, just having a hands-on wherever it suits you. So that is why we are going to share with you link centers all over India. We want you to do the hands-on so that you get the confidence, and this whole training program does not go waste. Okay, that is the ultimate aim. So pick and choose what is comfortable and convenient for you, and then go ahead and do it. So that is the ultimate aim.
And
So
one more thing the facilitation team does, ma'am, I have just seen that we also, surprisingly, we are getting the patient connect. As I said that, people contact us that this is the patient and we don't know where to go. So apart from all these things, directly patient families are contacting, because our numbers are in the website. So sometimes we get, so for that also we need to be, ready with, as I said, I'm struggling for Pune because we really don't have, and they need very, very specific. So even if you have any such, if you come across any such patients somewhere else, so for that matter also you can contact us. We'll help you with connecting to our partners in that particular state. That is also, we can help you with that.
And among your team also, no, see, as we said, see, you need to have some rapport. Even among your friends, like if you have oncologists, radiation oncologist or medical oncologist, like that also, no, it's good that you develop contacts also. Because see, the patient referral can come either from the patient, from the institution, or so many things. So having a good rapport with people, and then that is also for people who are starting and trying to do services, that is something I keep telling them. Because if you have something like that, it is helpful for the patient and for you. And then even like some NGOs or small groups which are willing to help, they are also there. They really want to do something, so they don't know to whom to provide the help and service. Whereas you already have patients who need it, so you just be a bridge, so that also can be helpful. So that's what, being open and willing to accept and get information if someone wants, and then linking them, those type of things, like little bit of personal relationship skills. Is there anything in the chat box? Let me have a look.
Nothing.
Okay.
Ma'am,
So
one more thing.
anybody else, Dr. Brogan, generally anyone who wants to have, like, ask any, you want to unmute and ask or anything, any practical issues or like regarding setting up and things, please do ask.
Ma'am, I want to mention how we help one hospital to procure the RMI, because sometimes people
Go ahead.
have, people have the question that the regional coordinators are based in a particular city and they're catering to so many. So how is it possible without physically visiting there? So here is a example I want to set. So as I said, I'm looking after Chhattisgarh. So there is a district called Balod. So there, one of the hospital doctor, she contacted me, and we have never met actually each other, but she's finished, completed our FCPM, and after that, she got in touch with me, and through emails and through Zoom meetings and through phone calls, all the guidelines were sent to her. She, went through it. She had her queries. We met on Zoom, and then she filled it up. Then I gave her the address, where to submit and everything. And one fine day, she sends me that, ma'am, finally I've got the RMI license. So that is, there's, you shouldn't be skeptical. Okay, I mean, how it's possible without even visiting? So it's possible. We have done it, and many of my colleagues are also doing it. So please reach out to us for any such kind of needs. Thank you.
The contact, the amount of contacts that they have is what helps in all these things. Because see, you may think, and within the four of them, they may get in touch. Okay, say for example, Sunanda has some issue. I'm just telling. Like, and to something which maybe Rontu would have had and dealt with it. So those things are there, no? So you may think, oh, what is this? Is this something strange to my institution or my place? Because see, you can have regional, cultural, so many differences and challenges and barriers. Okay, and as she mentioned in her presentation today, many salient, it's not a lucrative business. Okay, so that is something which is one of the building blocks really causing impediment in progress. Okay, so there are so many things, and already someone is in a state where they don't have financial support and things. So there you go, make it a business, it's not going to work. They won't even come to the center. They'll say, oh, no, I don't have the affordability. So even if they want to get support, they keep quiet. Many times it's The difficulty is born in silence. So there are so many things. So that's what. So it has its own challenges, but that is not putting people off. There are many centers and facilities available happening. Only thing, demand and supply is unable to be met. That's all. And then if you, with this RMI and things, availability, now slowly things are improving. Morphine and things are available. Only thing, bigger cities are having more availability. The smaller places still don't have. So that is where we have to take these across. There, if I'm not wrong, in this group, there were a few people from one state and things they were mentioning. Hopefully, even anything specific or challenges in that area, hope the course and the information has been helpful for them. As there are no more messages in the chat, I'm going to hand it over to you, Sri Priya.
Thank you, ma'am. I'm just informing that I have already shared the list of hands-on training centers in the WhatsApp group. You can go through that. And I think we have one.
There's one question, something in the chat. Will Pallium India help us collaborative research in palliative care?
I think that is a definite yes. We
Yes,
have
yeah.
a separate department
Research
for
team.
and innovation, which is headed presently by Dr. Deepak Sudhakaran, who is a very passionate doctor. So, Dr. Narayana, if I could request you, please do remind me after the session for his contact number. I will definitely brief him and have you his contact number so that you can take it up forward. And it was a very elaborative session, and I hope that you all might have got a lot of new knowledge from this session. And we do hope that these practical knowledges help you in setting up or in continuing the work which you are doing in your respective areas. With a gentle reminder that the next session is going to be our last session, and so please be prepared for that. This is Sri Priya along with Ms. Sunanda Samal and Dr. Radha Venkatesan signing off from the Tips Eco Hub. See you in the next session. Till then, everyone, take care. Bye-bye.
Thank you. Bye-bye. Take care.
Thank you, Sunanda. Thank you, one and
Thank you,
all.
ma'am. Thanks.
Thank you.